I'm Professor Margaret Maxwell and Deputy Director of the Nursing, Midwifery and Allied Health Professions Research Unit at University of Stirling. Within the NMAP Research Unit, I lead a programme on quality and delivery of care, and I've been engaged in health services research for several decades now. This is the PROPEL study, which is about implementing pelvic floor muscle training for pelvic organ prolapse. We know that about 40% of women can experience pelvic organ prolapse in their lifetime, and at the moment we often have recourse to surgery in order to manage this, which can often have complications, often leads to repeat surgeries. So if we have a more conservative way of managing it, it benefits women. So this would be implementing pelvic floor muscle training. We have completed a definitive multi-centre randomised controlled trial which was published in The Lancet last year that provided the evidence base that showed that pelvic floor muscle training delivered by specialist physiotherapists was beneficial to women with mild to moderate pelvic organ prolapse. The implementation problem that we now have is that we don't have enough specialist physiotherapists in the UK to be able to deliver this to all the women that might benefit from it. So what we want to do with the PROPEL study is to look at different ways of delivering the service through using different staff mixes, such as nurses or more junior physiotherapists. So can we train them, and can we see the same effects in women as we found in the definitive trial? So in the PROPEL study, we're going to use a mix of the RE-AIM framework, which has been developed by Russell Glasgow and colleagues at Virginia Tech, and also a realist evaluation. The RE-AIM framework, which stands for REACH, are you reaching the population that you want to reach, and gathering some information around that population. Effectiveness, obviously we want to know, is it still as effective? Are the same outcomes achieved by the different staff groups? Adoption, do staff actually take on the intervention itself and the organisations within which they work? Implementation, is the intervention itself being delivered in the way that we intended it to be, or are there adaptations made by specific staff groups? And obviously maintenance, we want to know that we can maintain those effects in the longer term. So that's the RE-AIM framework. A realist evaluation looks at the context of an intervention, the mechanisms of action of an intervention, as well as attending to outcomes. And it enables us to understand how those outcomes have been achieved, what has made it successful or unsuccessful. It's not an intervention that works in and of itself, it's the way that people engage and interact with an intervention that makes it work. Realist evaluations can be much more qualitative, although they do attend to outcomes, but in that way I think it complements the RE-AIM framework. So if you think about the first two components, which is reach and effectiveness, they're looking at individual level details of implementation. Are you reaching the individual population and the effectiveness of that on individuals? If you look at the next two components, which is adoption and implementation, they're much more organisational level details which you're taking into account, and maintenance can be either at the individual level or at the organisational level, so it provides a nice framework for looking at all the different aspects of an intervention. I think that given that there are so many theories, models and frameworks out there to choose from, I think it depends on the individual study, but a combination of more than one implementation framework or theory could offer the best scenario for making sure that you're attending to all the components that you want to measure or take account of.